So today we'll be discussing on antiplatelets and also on unfractionated heparin and low molecular weight heparin. Okay, so it's going to be a short class. I don't want to bombard you guys with a lot of information. So it's just going to be like not going to stuck with you. So maybe I'll just take it slow, So all right, so let's start the session. Can you guys able to see the presentation?
Yes, ma'am.
Okay. All right. Okay. So let's talk about the antiplatelets. Today I'll be discussing about the antiplatelets. So like aspirin. So we all know what are the antiplatelets available. So aspirin, diphenhydramine, adenosine diphosphate blockers, which are the clopidogrel, ticagrelor, and ticlopidine. And also we'll be talking about the unfractionated heparin and low molecular weight heparin. Okay, so that's all for the section today. So let's jump right into it. So we all aware about the mechanism of action of aspirin. So aspirin is inhibit the COX-1 and it inhibit the thromboxane synthesis and thereby it reversibly inhibit the platelet aggregation, right? So remember the term irreversible. So it reversibly inhibit the platelet aggregation. Now, let's have a look at the quick indications. So far in heart failure, in heart failure and angina, we discussed a little bit about the indications of aspirin, and not in heart failure. Sorry, don't confuse. So in hypertension and the angina, we discussed a little bit about the indication of aspirin. So we use it in acute MI for 30 days. So it seems to decrease the mortality. So it's not for the treatment again. So do not confuse. Aspirin is not for the treatment of acute MI. It is used to reduce it seems to find to reduce the mortality in acute MI. So usually if the patient comes with a heart attack, an emergency, we give the aspirin, chewable aspirin. So nitrate doesn't seem to work for those patients. So we usually give the aspirin like a dose of 160 to 162 milligrams. So it available in 80 milligrams children's aspirin, which is chewable, and it also available in 81 milligrams baby aspirin. So patients can take like 2 tablets and they can chew. So we give it for 30 days and then we reassess. So acute MI, so we'll be discussing it about tomorrow in MI. Acute coronary syndrome, we'll be discussing that. So then we use it for primary and secondary prevention of MI and stroke. So what is primary prevention? We already discussed the difference between primary and secondary. So primary prevention means patient never had a stroke or myocardial infarction in the future. So that is the primary prevention. Secondary prevention means patient had a history of myocardial infarction or stroke, and we are giving the aspirin for the prevention of reoccurrence. So that is secondary prevention. And we also use it for unstable angina or non-STEMI, we call it. So we'll be discussing about unstable angina tomorrow also. So again, it seems to find to decrease the mortality in patients with unstable angina. And it also decreases the risk of transient ischemic attack. So here, aspirin is the first choice, and we also give clopidogrel, which is an alternative for the patients who have salicylate hypersensitivity or allergic salicylate allergy. Now, we also used it for the prevention of venous thromboembolism. So especially after the DOT hip replacement. So we'll be discussing about venous thromboembolism in one section. So we'll know that high risk of surgeries, what are the risk factors of VTE. So we'll be discussing in that session. So usually used for the prevention of VTE, not for the treatment. Remember that. So the first choice of treatment of VTE is unfractionated heparin and low molecular weight heparin. So aspirin is actually used as a prevention. So you will get a better idea when we discuss about the VT later. Now, contraindication. So we all know like hypersensitivity is the contraindication in pretty much every drug. So I'm not gonna put I didn't put all the most common contraindications. So we'll just touch the important one that you have to remember. So history of salicylate induced asthma. So salicylate or NSAIDs induced asthma. So if the patients have an history of asthma which is induced by the salicylate, can we use the aspirin? Yes, we can, but we have to use in caution. So in those patients. So that's all. So but we can use though. Then the patients on methotrexate more than 15 milligram per week. So, for example, patient on rheumatoid arthritis. So it's not an absolute contraindication again. Can we use aspirin on those patients? Yes, we can. So how does, for example, let's take like a patient having rheumatoid arthritis and patient is on methotrexate, and we all know that rheumatoid arthritis is a risk factor for cardiovascular disease, right? And now patient have a heart attack, and so after the heart attack or myocardial infarction, can we give aspirin? Yes, we can, but we just have to need to monitor the methotrexate toxicity for that patient. That's all. So again, patient on methotrexate more than 15 milligrams per week, it's contraindicated, but it's not an absolute contraindication. The situation where we have to use, like I said, the rheumatoid arthritis example, we have to use it. We just have to monitor the methotrexate toxicity. Then we all know like Ray syndrome. So that is the reason it's very common. Like probably you all aware about the Ray syndromes. That's the reason we avoid the aspirin in childrens, especially who have fever due to viral infection. Right now, it's contraindicated in third trimester of pregnancy. Why? Because it can lead to early closure of ductus arteriosus. So and also it can cause renal and hepatic impairment, which I haven't included in this list. Now let's have a look at the adverse effect. So most of the adverse effect are dose related adverse effect. So bleeding is one of the most common adverse effect of all the antiplatelets, anticoagulants, and everything. So bleeding is always one of the most common side effect, adverse effect, and also it can decrease the leukocyte and platelets. So just remember that point. And there are other kind of adverse effect as well, like it decreases the uric acid. Sorry, it increases the uric acid level, and it can precipitate gout sometime. And it can cause rash, fatigue, hearing loss, and stuff. So, which at least remember the bleeding, and it decreases the leukocyte and platelet because we need the monitoring of this too, just in case if it goes very low. That's why. Okay. Bleeding is really important to notice. Like we have to educate the patient on bleeding. So that's why I put this tune adverse effect here. Now, let's have a look at aspirin toxicity. So excess use of aspirin can cause toxicity. It can be acute toxicity or chronic toxicity, right? So what is the lethal dose of aspirin? So if a single dose, SD stands for single dose here. So if the patient take a single dose of more than 500 milligrams per kilogram, then it can be a lethal dose to the patient. So that can lead to acute toxicity, even it can lead to death. So again, you have to remember the dose here, single dose of more than 500 milligrams. And if it is between 300 and 500 milligrams, it can lead to severe toxicity. So now let's have a look at the symptoms and how do we manage the toxicity. So if the patient have an acute toxicity, so we are classifying here as acute toxicity and chronic toxicity. Okay. Now, if the patient have acute toxicity, the most common symptoms here you have to remember in acute toxicity is hyperventilation. So whatever that I highlighted in red, at least you have to know that. So we have the nausea, vomiting, tinnitus, vertigo, hallucination, delirium, agitation. So if you look into here, we pretty much all the toxicity symptoms are related to CNS, right? So we have the most common things, which is those things will be seen in chronic toxicity as well. So it is similar symptoms as acute toxicity, but the most important thing you have to remember here is hyperventilation. So the people can feel hyperventilation, which result in acid-base imbalance. So usually in adults, it leads to respiratory alkalosis initially, then it followed by acidosis. So do not confuse. So we'll be talking about acid-base balance. So a lot of students, like a lot of still we have the confusion about how the acid-base balance work out in the body. So I'll be discussing about the acid-base balance in the end of the session. We'll have a quick look into it. So right now, just remember that it goes hyperventilation. So when it goes hyperventilation, it leads to respiratory alkalosis. So we'll be discussing how the hyperventilation result in respiratory alkalosis later. But right now, just focus it on. So initially in adults, it's respiratory alkalosis. Then it is followed by metabolic acidosis. But do not confuse. Most of the time, students confuse that respiratory alkalosis is like converting into metabolic acidosis. It's nothing like that. It's just respiratory alkalosis and metabolic acidosis is entirely different. But it's just the way of the body compensated. So respiratory alkalosis actually result in metabolic acidosis. It's not converting. It's just resulting in metabolic acidosis. Now, what if the patient, so we discussed that an acute toxicity, the patient feel respiratory alkalosis. But if the patient is on aspirin and if the patient is also taking CNS depressants, okay, so I just put this example here because you have to know the difference. Just think about, so patient is on CNS depressant. What would be the acid-base imbalance in adults? So it will be respiratory acidosis. Why? Because hyperventilation result in respiratory alkalosis. But if the patient is on CNS depressant too, even if the patient have acute toxicity by aspirin, the CNS depressants gonna depress the respiratory, respiratory system. So that result in hypoventilation. So that comes out as respiratory acidosis, not alkalosis. So you just have to remember that. Now, in children, usually it starts with metabolic acidosis and it leads to death. So initially it's seen as metabolic acidosis and it contributes to death. So again, patients can develop seizure in severe toxicity. That also one of the important things we have to remember. Now, let's move on to the chronic toxicity. So, chronic toxicity will have the similar to acute toxicity, all the symptoms, plus hearing loss, dizziness, tachycardia, and confusion. So, one thing you have to remember in chronic toxicity is the symptoms are slower and milder than acute toxicity. Okay. Now, in acute toxicity, what is the management of toxicity and how do we monitor? So, in mild to moderate, if you look up here, mild to moderate situation in chronic toxicity, if it is mild to moderate, we reduce or discontinue the salicylate. So again, we said that chronic toxicity, the symptoms are slower and milder. So if it is the symptoms are milder and moderate, we don't have to worry. We just have to reduce. Either we reduce the dose or we discontinue the salicylate, depends upon the condition of the patient. Now, what if it is severe? So if it is a severe, regardless if it is acute severe toxicity or acute chronic severe chronic toxicity, so regardless of acute severe toxicity or chronic severe chronic toxicity, we have to go with symptomatic therapy. Okay. So what is the symptomatic therapy? So let's have a look at few of them. So we have to monitor the salicylate level first of all, right? And sometimes we give the activated charcoal to decrease the absorption of aspirin. We do the urine alkalinization to increase the elimination of the drug, right? So we know that aspirin is acidic drug, so we have to alkalize the urine in order to increase the elimination of acidic drugs, right? So potassium, if the patient have hypokalemia associated with the toxicity, we have to give the potassium, we have to give the bicarbonate for the acidosis. So if the patient have acidosis, we give so acidosis, when I say acidosis, is metabolic. Okay, so we treat the metabolic condition. So metabolic acidosis, we give the bicarbonate, and dextrose. If the patient have hypoglycemia, we give dextrose. If the patient have seizure, we know diazepam is the one of the first line in status epilepticus. Like so, seizure, we give the diazepam, and we give sometimes we do the hemodialysis. Okay, so again, the most important thing you have to remember here is like hyperventilation related to acute toxicity, especially the acid-base imbalance, and pretty much all the toxic symptoms of acute toxicity and chronic toxicity is related with CNS. Okay. Now, symptom, again, the treatment, how do we manage? We manage with symptomatic therapy. We don't give any antidote or anything. We just give the symptomatic. We go with the symptomatic therapy. Okay. In toxicity, we always do the symptomatic therapy. We don't give the antidote. in this case. We gave the symptomatic therapy. Now, let's move on to some important keynotes here. So aspirin is usually taken with food. So as we all know, I didn't discuss about the drug interaction here. So I'm just going to give you guys as a homework for the drug interactions. It's really easy. Like most of the drugs that inhibit the clot can increase the effect and risk of bleedings in aspirin. Alcohol we should not use because more than 3 drinks of alcohol or something like can increase the bleeding. NSAIDs, right? So whatever the drugs that increase the risk of bleeding is comes in drug interaction. So I didn't put up here. So now the one thing is like you have to remember is like aspirin can increase the effect of hypoglycemic agent. Again, it's a dose dependent activity. Hypoglycemic agents like sulfonylureas and stuff. So it is a dose dependent, and it also sometimes it increases the level of valproic acid and digoxin. So that is the two things that you have to remember. And also it decreases the effect of uricosuric agent. So in adverse effect, I mentioned it can also cause gout. And if the patient is on any uricosuric agent for the gout, and it can decrease the effect and it can worsen the gout. So that is the another thing. Now, let's go back to the keynotes. Again, aspirin has to be taken with foods. With food, and the nighttime administration seems to increase the effect of aspirin. So we always recommend the patient to administer the nighttime. And if the patient has problem with administering at nighttime and patient wants to go with the morning dose, it's okay, that's fine. We don't have to force the patient to take at nighttime. It just seems to increase the effect, but it's totally okay to take in the morning too. Now, what is the perioperative? Let's have a look at some of the perioperative management. So if the patient is scheduled for a surgery, elective surgery, and now how do we have to stop the aspirin? So we know that in surgery we have to hold the most of the medications that can lead to bleeding, right? So here what we are doing is we have to stop aspirin 5 to 7 days before the surgery. So at least usually the physicians like hold aspirin 7 days before the surgery. If cannot, at least minimum 5 days they have to hold. 5 days before surgery they have to hold the aspirin. If the patient have a high risk of bleeding, so having said that, what are the reasons for high risk of bleeding? Let's say the patient is undergoing a surgery which can result in high bleeding risk. So for example, if the patient is having a neurovascular surgery, or if the surgery is related to neurology, or if there's something like open heart surgery, CAPS, right? Those are the high risk bleeding surgery. So high risk of bleeding. So in those cases, we have to hold the aspirin 10 days before the surgery. Okay. Again, usually 7 days before surgery. If not, minimum 5 days. And if it is high risk, 10 days. Okay. And we can restart the aspirin morning after 24 hours after the surgery. Okay. So after the surgery, the next morning we can restart, or we can restart if the surgery was at night, then we can restart the aspirin 24 hours after the surgery. Okay. What if now we discussed about the elective surgery now, because we know the patients know when the surgery is going to be, the physician is aware that they schedule the surgery. What if it is an emergency surgery? So like a patient is on aspirin, suddenly an accident happened, and the patient has to undergo an emergency surgery, and in that case we give the fresh platelet as an antidote for aspirin. Okay. uh, so here one another thing that you have to remember is like important information is like we have to continue the aspirin if the patient is high risk of thrombosis. Why? Because in some patients, especially the patients with let's say a few examples of high risk of thrombosis. Patients with heart valve, so mechanical heart valve, so those patients, and patients who have a history of stroke and MI in past 3 months. So those patients are high risk of thrombosis. So in those cases, we cannot hold the aspirin, even if regardless of surgery, we cannot hold the aspirin. So in those cases, we just have to continue the aspirin, and we have to monitor for the bleeding. And like I said, in that case also, we can give, if the bleeding becomes worse or something during the surgery, we can go with the fresh platelet. Okay, so that's all about the aspirin. Now let's move on to dipyridamole. We all, uh, it's I don't know if it's I think it's available in India too. Dipyridamole. So usually it comes in combination with aspirin, and it also comes as a single entity. So here we're going to discuss about the combination, the aspirin and dipyridamole. So the single entity of the dipyridamole, like it comes as a single entity. So which I think it comes as IV form, and it usually used for the um, coronary vasodilation during the myocardial perfusion imaging, the single entity of dipyridamole. But usually we use the combination of dipyridamole and aspirin in the prevention of TIA and stroke. Okay, so here we are going to discuss about the combination, not the single drugs. Okay, so whenever I discuss all the indication, contraindication, it's just with aspirin. Um, here, so again, the mechanism of action is like, again, it's same as the aspirin. It inhibits the platelet aggregation, but the one another additional effect of dipyridamole is it can induce vasodilation. So it has the vasodilation effect. Okay, so indication, we actually used it with the combination, like I said, and we use it for the secondary prevention. So I already discussed what the difference between the primary prevention and secondary prevention. So we use it for the secondary prevention of transient ischemic attack or stroke. Okay, now let's have a look at the contraindication. It is pretty much similar to ASA because it has the ASA in it. So it comes in combination with ASA. So we similar to ASA, all the contraindication. And the other thing is additional contraindication is fructose intolerance. Why? Because it's the capsules contain the lactose and sucrose. So patients who have the intolerant to fructose, it can develop fructose intolerance or galactose intolerance in those patients. And adverse effect is, again, it's similar to aspirin. In additionally, it can cause headache. Why? Because it has the vasodilation effect. So headache is due to excessive vasodilation. It can cause headache. So headache, it goes away after a few days. If the patient have really bad headache, can we give ibuprofen? No, we cannot, because it can interact and it can increase the risk of bleeding. So we go with the acetaminophen in those patients for the headache. If the patient is really complaining about the headache, we can ask them to take an acetaminophen, not the um, any kind of NSAIDs. Okay. And the keynotes here to remember is we have to make sure to avoid an unstable angina. Why? Because it has the vasodilation action. Otherwise, we can use, because aspirin we used in unstable angina, right? And the prevention to decrease the mortality in patient, we use aspirin in unstable angina. But here we have to avoid, just because of the vasodilation action, it can cause reflex tachycardia, which is not good for the unstable angina. So we have to avoid an unstable angina. Dose for transient ischemic attack doesn't offer the myocardial protection here. So why? Because in the combination of dipyridamole and aspirin, aspirin is, I guess, it's only contained 25 milligrams of aspirin, so which is not gonna provide any protection. Myocardial infarction. So after the myocardial post MI, if we recommend this class of drug, it's not gonna offer the myocardial protection. Okay, so again, it's because it contains only 25 milligrams of aspirin, and it has to dispense in original container because it's moisture sensitive. So we know that in container it has the desiccant, so we have to make sure we dispense it in the original container. We do not open the container, and we don't want to open the container and dispense the medication. And can we crush this dipyridamole? We cannot. Like, unlike aspirin, we can chew. We have it's available in chewable form and stuff. But in dipyridamole and aspirin combination, we cannot crush, or we cannot let the patient chew this tablet. Or we can, in patients having dysphagia, like difficulty in swallowing, we cannot even crush it and administer to. Can we administer it through the nasogastric tube? No, we cannot. So that is the another thing you have to remember. Okay, so it's really easy, the dipyridamole. Now let's move on to ADP blockers, also known as T2 white-full inhibitors. So ADP stands for adenosine diphosphate, right? So here I put a table to know the difference between three drugs. So it's usually the most commonly available medication in this class is clopidogrel, ticagrelor, and ticlopidine. Sorry. Okay. So the effect is here. If you notice the effect of the medication on platelets, so most of the medication is like reversible, except the ticagrelor. Like not most, like just there is only three. So clopidogrel is irreversible, ticagrelor is reversible, ticlopidine is irreversible. So here you have to remember the tica. So I highlighted in the red color. So ticagrelor is having the reversible action, and it's not a prodrug. So um, again, the rest of the medication is prodrug, so it has to be activated with the enzymes once it reaches the body, right? So convert into active metabolites. But in ticagrelor, it's not a prodrug. Let's have a look at the indication here. So clopidogrel used in the secondary prevention of myocardial infarction and stroke. Again, we use the first choice is like aspirin all the time. We use the aspirin as the first choice. The patient who cannot tolerate the aspirin, we give the clopidogrel. Okay, and we give it with the combination with aspirin for stroke prevention in AFib, which we will be discussing in stroke and in cardiac arrhythmia. So do not worry about that. We will be discussing in detail. And we also give it combination with the aspirin in unstable angina and acute MI and peripheral artery diseases. So again, we'll be discussing the unstable angina and acute MI tomorrow. So again, do not worry. And let's have a look at the indication of ticagrelor. So we give it with aspirin in combination with aspirin for the secondary prevention of myocardial infarction in acute coronary syndromes with patients with the PCI. If the patient undergo the percutaneous intervention or coronary angio bypass graft and post MI. So in those patients, so as we see here, it's almost all the time it used with in combination with aspirin, right? And it used for the secondary prevention, not the primary prevention. And always the first choice is aspirin. And if the patient cannot tolerate aspirin, we go with the first line, like for the if the patient cannot tolerate the aspirin, first we go with the clopidogrel. That is the first choice all the time. Okay, and ticlopidine is not commonly used in practice, but it can be used for primary and secondary stroke prevention, and also in patients have post intracoronary stent. So again, like I said, it's not commonly used in practice. Okay, now let's have a look at the area here. We have quite a lot of area, but like GI bleed, it can cause rash, headache. But the most important thing you have to remember is thrombocytopenia here. So it can cause thrombocytopenia. So because of that reason, we have to increase the first year monitoring. Okay, so we have to monitor the CBC every 4 weeks at least. Every weeks for at least 4 weeks for first year of initiation of clopidogrel, and it also can increase the cholesterol level. So here you have to remember that we have to monitor the CBC for every week for 4 weeks in the first year of initiating the therapy. Okay, and there are other adverse effects as well, like it can increase cholesterol level, it can cause bleeding, right, diarrhea, headache, and those things. And let's have a look at some adverse effect of ticagrelor. So it increases the uric acid, serum creatinine, and arrhythmia. So again, there are other adverse effects too, which you can go through. Like in the textbook, you will see like it can cause again the bleeding, headache, all those things. So these are the most common. Like so, in most classes, we can see the bleeding, headache, and diarrhea. So I didn't put that, but here you just have to remember like the difference in the area. Here, ticagrelor can increase the uric acid level. So we said that in aspirin, aspirin also can increase the uric acid level, and it can also decrease the effect of uricosuric agents, right? So same like ticagrelor can also increase the uric acid level. Now, ticlopidine has quite a lot of area. That is the one reason that it may not commonly used in practice. It can cause diarrhea compared to other two. It can cause a little bit severe diarrhea. So we recommend it to take with food. So it's not because of diarrhea. The reason is that we have to monitor the LFT, alkaline phosphate, at baseline, then during the first 4 months. So it's actually kind of quite a lot of monitoring for the patient. When we initiate the patient on ticlopidine, that is the one reason it's not a usually it's not a good appealing for the patients or physician to initiate this patient on this ticlopidine. Why? It's because it can increase the ALT and AST, and also it can cause thrombocytopenia. So like clopidogrel, we have to monitor the CBC here. Instead of every week, we monitor it for every 2 weeks for 3 months. In clopidogrel, we monitor every week for 4 weeks in the first year, but here we monitor every 2 weeks for 3 months. Okay, and it can also increase the triglycerides. So it pretty much have same adverse effect of clopidogrel, but additionally it can increase the ALT and AST. Okay. Now, if we look into the contraindications, if we when we discuss about the drug interaction, pretty much all the drug interaction like CYP enzymes related in drug interactions is contraindicated, and also in hypersensitivity and like bleeding disorder we have to be very careful. So I didn't put those I didn't put the contraindication here, but we will discuss the drug interaction though. Now let's have a look how do we manage the pre-op. So it's similar as aspirin here, clopidogrel. We have to discontinue 5 to 7 days pre-operative. Again, we have to consider the high risk of thrombosis. If the patient have high risk of thrombosis, we have to continue the medication. We cannot stop. Aspirin it was the same, right? In 5 to 7 days, but if it is high risk of bleeding, 10 days, right? So here again, it's 5 to 7 days pre-op. Ticagrelor, it's 5 days. We just have to discontinue 5 days before operation or surgery. Ticlopidine, again, if you see here, we have to discontinue it 14 days before the surgery. So as you could see here, like the ADR in terms of monitoring, everything, it's pretty much difficult to maintain. And even pre-op, we have to discontinue it like 14 days before it. And even if it is high risk of thrombosis, we have to discontinue the ticlopidine. But when it comes to clopidogrel and ticagrelor, if there is a high risk of thrombosis, we can continue the therapy. So that is the reason that it's not commonly used again. Okay. Now, what are the antidotes for these medications? So for clopidogrel, platelet transfusion, and for ticagrelor, it's tranexamic acid, which is a fibrin stabilizer. And aminocarporic acid also is a fibrin stabilizer. And we can also give factor 7A. It can decrease the bleeding. And in ticlopidine, we do the platelet transfusion, but we do not use the fresh frozen plasma in that. And now let's have a look at a few drug interactions here. So mainly, we said clopidogrel is a prodrug. So it requires one of the main enzyme, CYP enzyme, which convert the prodrug into active metabolite is the CYP2C19. So if we give 2C19 inhibitors, it can actually decrease the effect of the medication, and it decreases the activation and effect as well. So let's have a look at the most commonly used 2C19 inhibitors, like is PPI, proton pump inhibitors, and repaglinide, anti-diabetic medication, right? So PPI, when I say PPI, two things you have to remember is like pantoprazole and lansoprazole seems to have less 2C19 inhibition. Okay, so if we have to use PPI in patients who is on clopidogrel, we can go with pantoprazole or lansoprazole. So again, among the PPI, pantoprazole and lansoprazole, so it's based upon the studies, So PPI, pantoprazole and lansoprazole seems to have less inhibitory action. So we can, if we have to use PPI, we can go with pantoprazole and lansoprazole. And blood thinners. So if you use the blood thinners along with other blood thinners, it can increase the risk of bleeding. And azole antifungals is also one of the 2C19 inhibitors, which can decrease the activation and effect. Okay. Now let's move on to the ticagrelor. We have the CYP3A4 inhibitors. So it is metabolized. So we said it's not a prodrug, so we don't have to worry about the activation or anything. So here we have to worry about the metabolism. So 3A4 inhibitors. If we give inhibitors, it increases the effect of the medication. If we give the inducers, so it is metabolized by this enzyme. So if we give the inhibitors, it increases the effect. If we give the inducers, it decreases the effect. So let's have a look at few of the inhibitors. So we have the azole antifungals, macrolides, diltiazem, right? So there is a long list of all these inhibitors and inducers, right? So few of the example is like azole, macrolide, diltiazem, protease inhibitors are the examples for inhibitors, and for inducers, rifampin, phenytoin, carbamazepine, we can say. So if it is inducers, it decreases the effect. Again, blood thinners can increase the risk of bleeding, right? And ticlopidin, it increases the level of phenytoin and theophylline. And again, blood thinners can increase the risk of bleeding. Okay. Now, let's look at some key points here. It seems to have a close sensitivity between the clopidogrel and ticlopidin. So most of the time, we do not switch the patient from clopidogrel to ticlopidin. So if the patient is not tolerating the clopidogrel, we try to switch from clopidogrel to ticagrelor. Okay. So ticagrelor is the alternative for the patients who cannot tolerate the clopidogrel. Do we have to do dosage adjustment in renal impairment? No, we don't have to. So no dosage adjustment is required in renal impairment here. And ticagrelor can be crushed. So we said dipyridamole we cannot crush. Here ticagrelor can be crushed. We can make into a powder. We can, patients with dysphagia, we can add into water, or we can administer it with nasogastric tube. So we can crush. And one of the most important reason why ticagrelor is an appealing option in patient undergoing elective intensive surgery is because we said in the previous slide that it has the reversible effect. So that is one of the most reason why it make this drug an appealing option in patient undergoing elective intensive surgery. Okay, because it has the reversible effect. The rest of the two class medication, not class, like two medication have the irreversible effect, except the ticagrelor has the reversible effect, right? Now, that's all about the ADP blockers. Again, adenosine diphosphate blockers. Do you hope it's clear so far? Do you guys have any questions so far? So we pretty much completed the antiplatelets now. Now we are going to move into unfractionated heparin and low molecular weight heparin. So here again, I put up the, I put a drug, I put a table. So we can just compare the unfractionated heparin and low molecular weight heparin, and we can study, right? Okay. Now, most of the time we get confused with the low molecular weight heparin and unfractionated heparin. So whenever you see heparin, just heparin, that means the unfractionated heparin. So what are the examples of few examples of low molecular weight heparins, guys? Give me a few examples.
Enoxaparin.
Yes, enoxaparin, dalteparin, right? Nardoparin. So we have a lot of parins. So those are the low molecular weight heparin. So do not confuse the heparin with low molecular weight heparin anymore. So whenever you see in a case study, if you see heparin, that is unfractionated heparin, low molecular weight heparins. Usually, I guess the low molecular weight heparins comes in pre-filled syringes. I don't know if you come across with like any pre-filled syringe of low molecular weight heparin. There are times it comes in vial. So no longer they don't use the multi-dose vial. They use usually because of a lot of medication event has been happened by wrong administration of the dose and stuff. So now it comes in, it is available in multi-dose vial, but most commonly it is available in pre-filled syringe, which make the administration much easier for the patient. Okay, now let's have a look at the mechanism of action of unfractionated heparin and low molecular weight heparin. So heparin accelerate the inactivation of an active coagulation factor 2A and 10A. So here remember these two factors. So 2A and 10A. So 2A is thrombin, right? So thrombin and 10A. How? By enhancing the effect of antithrombin. Now, the difference is here is the unfractionated heparin inactivate both the factor 2A and 10A equally, but when it comes to low molecular weight heparin, the low molecular weight heparin has 2 to 4 times greater effect on 10A than 2A. See the difference? So again, both inactivate the factor 2A and 10A. But the difference is that when it comes to low molecular weight heparin, it inactivates the factor 10A 2 to 4 times greater than 2A. Okay. Now, kinetics is really important to know when it comes to unfractionated heparin and like heparin. Let's call it heparin. Okay. Now, in heparin, we all know that heparin has non-linear dose-dependent kinetics. Why? Because in low dose, the heparin is removed by a saturable system. So what is the example of a saturable system? So like endothelial system. So at low dose, it is removed by saturable system like endothelial, and at high dose, it is removed by a non-saturable system, which is renal. So again, it follows the non-linear dose-dependent kinetics. So that is the one reason it is really hard to because of this altered kinetics of the heparin, it is really hard to monitor the heparin. Um, and we have to do this. We have to do the monitoring, not hard. We have to do the monitoring of the heparin. But when it comes to low molecular weight heparin, it is removed by non-saturable system renally. So again, non-saturable system, which is renal. So it's only removed by renal and it's not dose dependent. So one thing here, the advantage of unfractionated heparin over low molecular weight heparin is that we can use the unfractionated heparin in patients with renal impairment. Why? At low dose, it is removed by endothelial system, not renal. So that is the one pro about the unfractionated heparin when it comes to kinetics, because it is can be used in renal impairment. Okay. About the protein binding, the heparin has high protein binding, and so because of that the reason itself, it has more interaction compared to low molecular weight heparin. And also it is dose dependent, right? So it has a dose dependent short T half, but while low molecular weight heparin has low protein binding and it has a long T half, which gives an advantage that we only have to do once daily dosing for low molecular weight heparin. Okay. Again, kinetics non-linear, dose-dependent heparin, but low molecular weight heparin is not dose-dependent, and it is eliminated renally. But heparin is at low dose removed by endothelial, high dose it's removed by renal, which gives an advantage that we can use it in renal impairment patient. And when it comes to protein binding, heparin is high protein binding and it has the short T half, while low molecular weight heparin has low protein binding and long T half, which gives an advantage for the once daily dosing, okay, or daily dosing. Now let's have a look at the indications here. So both the unfractionated heparin and low molecular weight heparin I discussed when I mentioned the BT, I said that the first choice of treatment is unfractionated heparin and low molecular weight heparin. So it is used in the treatment and prevention of DVT, deep vein thrombosis. Okay. Sometimes we use the heparin, very low dose. Okay, very low dose of heparin. So it actually, we all know that when we give the IV, we use the normal saline flush to clear the IV line, right? But also we can use the heparin. So it actually comes in pre-packaged heparin with low dose, which is usually used for the IV flush. So it can use to flush the IV line. Again, it's low dose. Okay. So it also prevents the clotting during the dialysis. And in low molecular weight heparin, we also use it for the treatment of unstable angina and STEMI. We'll be discussing that in detail tomorrow, so you will get an idea. So contraindication here it's really important to know is HIT. We know what is HIT. What is HIT? HIT is heparin-induced thrombocytopenia. So if the patient have a confirmed type 2 HIT, so there is two types of HIT, type 1 and type 2. We'll be discussing in next slide. So type 1 and type 2. So if the patient have a confirmed type 2 HIT, it is contraindicated. If the patient have an active bleeding, like if the patient have a GI ulcer or hemorrhagic stroke, we cannot use heparin and fractionated or low molecular weight heparin. If the patient have a hemophilia is a clotting disorder where a patient is not able to, like the blood is not able to clot, right? It cannot form, so it's a clotting disorder, so we cannot use the heparin in those conditions as well. And if the patient have a recent surgery or severe liver impairment, we have to monitor for the patient. And we try to avoid in ischemic stroke as well until the hemorrhage is ruled out. So in hemorrhage, we cannot use hemorrhagic stroke. So if there is an ischemic stroke, we have to rule out the hemorrhage first before initiating the therapy. Now, what are the adverse drug reaction? Again, allergic reactions. So patients can develop fever, chills, rashes, all the hypersensitivity, right? And sometimes hematoma at injection site. So we usually do not recommend to inject IM. So it usually the route is sub-Q or IV. So low molecular weight heparin is sub-Q and IV and sub-Q. So never go IM. Okay. And hyperkalemia, it can cause hyperkalemia by decreasing the aldosterone level, and sometimes it can cause reversible osteoporosis. So if you used it for a long term, like for 3 to 5 months, it can cause osteoporosis. Now you might be wondering, can we use unfractionated heparin like 3 to 5 months? Is it like, so usually at hospital we used unfractionated heparin because it's really hard to, it requires the monitoring, but we usually go with low molecular weight heparin. If the patient has, patient can inject sub-Q, it's sub-Q, and patient can like insulin, they can take low molecular weight, administer the low molecular weight heparin. So when we discuss the VT, venous thromboembolism, we will see the patients where we have to go with long-term low molecular weight heparin in some patients. So yes, we use it for a long-term therapy too, like for 3 to 5 months. So sometimes it can cause reversible osteoporosis. Again, it's reversible, so not major concern here. The one thing that we have to concern is HIT. So let's have a look at the HIT. So we have two types of HIT, type 1 and type 2. So type 1 is less serious and type 2 is very serious. So we will discussing the how to manage the HIT 2. So type 1 is not immune mediated. So let's see the difference here. So type 1, it's not immune mediated, but type 2 is immune mediated. Okay. And type 1 is the platelet count remains above 100,000 per mils. So platelet count is not gonna affect much, so that is okay. But when it comes to type 2, the platelet counts drops below 100,000 per mil. So that's a serious situation. Now the onset. Onset is 2 to 5 days of initiating therapy. So usually once we initiate the therapy, like the unfractionated heparin or low molecular weight heparin, usually the unfractionated heparin, not low molecular. So it is heparin-induced thrombocytopenia, right? So usually, when after we initiate the therapy, within 2 to 5 days, we can see type 1 HIT. Right? Not in all patients, some patients, okay? So usually the onset is 2 to 5 days. When it comes to type 2, the onset is 5 to 14 days, okay? Again, 5 to 14 days, but it may develop in 24 hours if the patient had heparin in the last 90 days. So remember that. So if the patient had heparin in last 90 days, patients can develop 24 hours, like may develop the type 2 in 24 hours. So that means if the patient took the heparin in last 90 days, 2 weeks before, just let's say the patient take the heparin like 2 weeks before, and the patient develops the reaction, and so now we have to screen out if it is type 1 or type 2. Because why? Because it can develop in 24 hours. Like, so if the patient develop the symptoms like within 2 days or within 24 hours, we can doubt if it is type 1 or type 2. But if the patient had not used the heparin last 90 days, and if the patient develops symptoms in second day or like in 24 hours, that means it's type 1, it's not type 2. Okay. And when it comes to complication, there is no complication in type 1, but in type 2, we have the complication, which is really important to know. So it includes the formation of white thrombosis. So what is white thrombosis? White thrombosis is just nothing, but it's just the platelet combination of platelet and fibrins. So which is a serious complication. It can lead to stroke, myocardial infarction, DVT, gangrene, and so and so. So it's really a very serious complication. And how do we manage the type 1? We just have to, let it go. We don't even have to discontinue the therapy. It's just, as long as the platelet count is okay, we don't have to worry much, and there is no complication. So we just have to let it go. So we do not, usually the discontinuation is not required. But when it comes to type 2, we have to discontinue the heparin. Okay. So once we discontinue the heparin, the platelet starts to rise in within 3 to 5 days. Okay, so we are good with the platelet. What about the thrombosis? Whatever the white thrombosis has formed, the risk remains high for 30 days. See, so we discontinue the heparin, but still the thrombosis risk remain high for 30 days. So we cannot give no more heparin or low molecular weight heparin. Here we have to use an alternative, and the best alternative and with better evidence is ergotraban. So we use the ergotraban. We have another class of medication which is fondaparinux, but it's not commonly used. But the first, not I won't call it as a first choice, better option. I call it as a better. We can call it as a better option with a better evidence is ergotraban. So we use this medication. So especially in patients who are critically ill due to type 2 reaction. Okay. When I say type 2, don't go with type 1 reaction, hypersensitivity reaction. It's HIT, okay? Type 2 HIT. All right. Now, why? Because it makes more better option, because fondaparinux is actually we have to avoid in patients with creatinine clearance less than 30 mL per minute. But when it comes to ergotraban, we can use it in even the creatinine clearance is less than 30 mL per minute. And also it's a good choice in patients who are on dialysis, and it actually maintains the patency of dialysis line. So again, with all reasons, it's the ergotraban has shown better evidence, so it's the better options when it comes to alternative for type 2 HIT. Okay, so are we clear? Now let's see some drug interaction and monitoring of unfractionated and heparin and low molecular weight heparin. So drug interactions first. So clot inhibitors such as oral anticoagulants, aspirin, thrombolytic agents, which can increase the risk of bleeding. So we have to monitor. Okay. IV nitroglycerin. So yesterday when we discussed about the nitrates, we said heparin resistant. So it can decrease if we give the nitrates along with heparin, it can decrease the heparin effect. So we have to monitor again. Unfractionated heparin can cause false low aminoglycoside level. So this is another thing that you have to remember in clinical practice setting. Like if you see a nurse withdrawing a blood from the patient for the serum analysis of aminoglycoside, and we just came to notice that the patient just used the heparin for IV flushing of, so we said that we use the heparin for IV flush, right? Flush the line, IV line. So we noticed that the nurse used the heparin to flush the line like a few minutes before. Now the nurse is drawing the blood for the serum analysis of aminoglycoside. So we have to make sure that they're not doing that, because it can cause false low aminoglycoside level. So again, we have to make sure that we are not flushing the IV line. containing heparin. So before withdrawing the aminoglycoside sample. Okay. Now let's have a look at the monitoring here. So both for unfractionated and low molecular weight heparin, we can monitor the platelet every 2 to 3 days for HIT. So we usually don't want to monitor for all patients. Only in case of HIT, we have to monitor for 2 to 3 days. Leg swelling. So it is basically the monitoring is, if you see here, the monitoring is just to make sure if there is a response to the therapy. So when it comes to DVT, we monitor for the leg swelling. So just to monitor for the improvement in DVT, leg swelling, if there is a decrease in the leg swelling or increase in the leg swelling. So leg swelling when it comes to DVT. And for bleeding, we go with the hemoglobin, so HPG. So and let's have a look at some of the lab work. So usually, in unfractionated heparin, I said the kinetics is very complicated kinetics. So we need to monitor the response. It is really required for unfractionated heparin, but not for low molecular weight heparin. Why? Because it has a predictable dose response curve, right? So it has a predictable dose response. But if we have to use it, if some case the physician has to want to check the monitor the lab response while using the low molecular weight heparin, they can go with the same protocol. No worry. Like we can go with the same protocol we use for the unfractionated heparin. But generally, we do not. We don't want to monitor. We usually do not monitor the response for unfractionated heparin, but we do. Sorry, we do not response require sorry again just confused here. So we do not monitor the response for low molecular weight heparin, but for unfractionated heparin we do. Okay. Now what are the common lab work we do is like APTT, which is very common. So we usually monitor every 6 hours. In children, we use it like every 4 hours we monitor it, and after initiating the therapy, and we do it like 4 times daily. Okay. Again, we monitor it for 6 hours in adults and every 4 hours in children's for after initiating the therapies for 4 times daily. If the patient is taking high dose of unfractionated heparin, APTT is not gonna a good choice of monitoring the response. Okay, it's not useful. So the another thing is anti-activated clotting time, ACT. So it is used to monitor the effect of high dose of unfractionated heparin before, during, and shortly after the surgery. So again, why we use the activated clotting time? So we use it to monitor the effect of high dose of unfractionated heparin. So we said that APTT, we usually it's not useful in patients taking the high dose, but ACT we can use it in high dose, especially in surgeries before, during, and shortly after the surgery. We take the activated clotting time. We check for the activated clotting time. Now we also have the anti-10A level, so we can monitor that as well. And when it comes to pregnancy or if the patient is underweight, we take the level of anti-10A2, okay, to monitor the response. Now, it's really important to know how to adjust the heparin dose based upon the APTT. It's really pretty simple. So do not get don't get intimidated with the big table up here, but we can make it really simple here. So first, let's focus on the one with I highlighted with red. So if the APTT is 46 to 70, okay. So again, the APTT is 46 to 70, okay. So let's start from there. So that means we don't need adjustment. The patient is within the target, no dose adjustment. So we are clear about that. Again, if the APTT is 46 to 70, we need no dose adjustment. Okay. So that's clear. Now, let's see what if it's, so now let's go with what if it's go above 90. Okay. Now we are going above 90. So again, 46 to 70, no dose adjustment. Okay. Now above 90, which means 3 times the mean normal, okay, more than 3 times the mean normal, what we have to do? We have to stop infusion. So that is the only where we stop the infusion. Okay, so it's pretty easy to remember. Again, 46 to 70, no dose adjustment. If it goes above 90, we have to stop infusion. So that is the only where we required to. So if the physician come and ask what is the adjustment I have to do, in this case, when you say if it is the value is above 90, right away, the thing they have to come to the mind is stop infusion. And for how long? That is the next question. For 1 hour. Okay. So again, if you see the number above 90, stop infusion. That is the first thing. Even if you don't remember how many hours, at least you have to remember stop infusion. Stop infusion for 1 hour and reduce the dose. So we stopped infusion for 1 hour. Now we have to reduce the dose. So reduce the dose by 3 units per kg per hour. So even if you don't remember how many units you have to reduce, the main important thing you have to remember, stop infusion and reduce dose. First thing, stop infusion. Whenever you see above 90, stop infusion. Okay. For stop infusion for 1 hour and reduce dose by 3 units. So if you see a unit like if you see here, all the units are like pretty much when they decrease the dose or increase the dose, they increase it with a single digit unit. So if you see reduce dose by 10 units, that's absolutely wrong. So right away we can say it's wrong. If you see increased dose by 20 units or 15 units, that is wrong. So always the reducing or decreasing dose is always with single digit units. So it can be 2, 3, 4, or so that is another tip you can remember. So again, if it is above 90, stop infusion right away for 1 hour, then reduce dose by 3 units. Now let's see what if it's between. So we said 46 to 70. You have to remember that number, 46 to 70. Okay, that you have to by heart. 46 to 70, no, it's target, no dose adjustment. We said above 90. So we already know above 90, we have to stop infusion. That is the only place we have to stop infusion. And rest of the situation, we don't stop infusion, if you could notice. So only place where we have to adjustment like stop infusion is above 90. Now what is in between? So 46 to 70 is target, and above 90 we have to stop. If it is between that 71 and 90, we only have to reduce the dose. Okay, so remember that. Just remember reduce dose. We have to reduce the dose. So physician asks for you what is the adjustment I have to do. You say you have to reduce the dose. Now the physician asks how many units. Then you have to say it is you know that from that it's a single digit unit. So you don't have to go for like 6 or 8 units. You just have to go with below, right? So even if you say like physician, by mistakenly you said 1 unit, it's not going to make much harm to the patient. We just have to reduce again another 1 unit. But basically, try to remember like it's 2 units. But again, the important point is here what to do. Like either we have to stop infusion or reduce dose. That is the important thing. So again, above 90 stop infusion, 71 to 90 reduce dose by 2 units per kg per hour. Now, what if it's below that? So if the APTT is below 35, now we're going to below 35. Okay, so below 35 means we have to give a bolus. So in both cases, if we see where we have, like if it goes below the target, then we have to give a bolus. So, and also increase the dose. So whenever you see a value below 46, 2 things you have to recommend the physician. If the physician asks for a recommendation, give the bolus and increase the dose. Again, give the bolus and increase the dose. Now, it's easy to remember the units here. If it is below 35, we have to give a bolus of 80 units per kilogram. Okay, and we have to increase the dose by 4 units per kg per hour. Okay, so again, we give the bolus of 80 units per kilogram. Here, the bolus is 2 digits. Okay, so we give the bolus of 80 units per kilogram. then we increase the dose by 4 units per kg per hour. What if it's between 35 and 45? So here we give the bolus of 40 units. So it is half the dose of below 35. So 40 units per kg, and it is half, just half, make it half. So again, it's pretty much easy. Always memorize the target, like the normal level. So it is 46 to 70. We know the normal. Now, if you see a number above 90, right away tell the physician to stop the infusion, or recommend, not tell the physician, we have to respect the there is a respect. So we have to recommend the physician to stop the infusion. So for 1 hour. So at least you should tell the physician, hey doctor, I think we have to stop the infusion for this patient, and maybe you have to reduce the dose, right? And if you see in between 71 and 90, then we only have to do is reduce the dose. If you see it below 46, 2 options. If it is below 35, give the bolus. In both cases, give the bolus and increase the dose. But if it is below 35, we give the bolus of 80 and we increase by 4 units per kg per hour. And just make it half if it is between 35 and 45. See, it's pretty much easy. So what to do after doing the adjustment? We have to retest after 6 hours. So we have to retest the APTT after 6 hours in all cases for 4 times. Then every morning if it within the range. Okay. So that is how we adjust the heparin dose based on the APTT. Do you guys have any questions? Okay. So now let's have a look at the protocol for overdose in when it comes to heparin. So the following protocol, we can use it for both unfractionated heparin and low molecular weight heparin. But low molecular, so we all know that what is the most commonly used antidote is protamine sulfate. But low molecular weight heparin reversal by protamine is actually incomplete. So we usually don't recommend, but we mostly use the protamine sulfate when it comes to unfractionated heparin. But can we use it in low molecular? Yes, we can. But usually we use this protocol, like protamine protocol in unfractionated heparin. So if there is an elevated APTT, we already discussed how to do the adjustment, and there is no bleeding, we usually hold the heparin, we monitor the patient, restart the therapy at low dose. If there is a bleeding, okay, in case of overdose, we are talking, okay, we are not talking based upon the adjustment like heparin adjustment, that is based upon the APTT. Here we are talking about the overdose, which is a confirmed overdose, like accidentally nurse injected instead of injecting like 5,000 units, they ended up injecting 100,000, double the dose. And in that case, overdose, how do we manage? That is, so this protocol is for the overdose. So if there is a bleeding, we give the protocol. In bleeding, always the APTT will be above 90. So especially when it comes to overdose. So in bleeding, we give the protamine sulfate. So there is a dose instruction for protamine, which I haven't included here, but we just have to make sure that infusion rate. So when the nurse is giving the protamine sulfate, we have to make sure that the infusion rate is not exceeding 20 to 50 milligrams per minute. So 20 milligrams per minute and 50 milligrams, sorry, it's not 50. So I think I made a mistake here. Just a minute. It's not 50 milligrams per minute. It's actually 50 milligrams per 10 minutes. I should be careful here. So let's put 10 minutes and 20 milligrams per minute. Okay. So either the infusion rate has to be 20 milligrams per minute, or it has to be 50 milligrams per 10 minutes. So we don't want to exceed this rate because it can cause hypertension and anaphylactic reaction. Now, fresh frozen plasma also can be used in the management of overdose. Now, let's have a look at the key points up here. So, low molecular weight heparin is the first choice in pregnancy, but we try to avoid in prosthetic valve. Why it is first choice in pregnancy? Because again, unfractionated heparin can cause high risk of bleeding. When it comes to low molecular weight heparin, the risk of bleeding is less. So that is the reason we go with low molecular weight heparin in pregnancy. But why we have to avoid in prosthetic valve? We mentioned that prosthetic valve patients are high risk of thrombosis. So we need more. I won't say that we need more bleeding. That is the wrong term to use. We say we need more thinning, like we have to more thinning of the blood, right? So we have to go with unfractionated heparin. Okay. Now avoid the multi-dose vial. Like I said, low molecular weight heparin comes in multi-dose vial as well, except the natroparin in pregnancy. Why? Because in multi-dose vial, as we all know, they use the preservative, which is benzyl alcohol, which can increase the risk of fetal toxic syndrome. So, except the natroparin, most of the low molecular weight heparin multi-dose vial has the benzyl alcohol, which is contraindicated in pregnancy. Low molecular weight heparin, I already mentioned it, available as sub-Q. And where do we inject? We inject in the U-shaped area surrounding the navel. So usually like the lower abdomen. Can we go on thigh? We usually don't go on the outer thigh because sometimes when we inject in the outer thigh, there is increased risk of um, subcutaneous injection can turn into IM injection, so and it can cause hematoma. So we usually go with the um, U-shaped area surrounding the navel. And unfractionated heparin, we have intravenous and we also have the deep sub-Q. So IV has the immediate onset of action, which is most preferred route for heparin. And deep sub-Q is have delay onset by 1 hour, less than 1 hour. So and also it has variable bioavailability. So we usually the preferred route for heparin is IV. Okay. Now let's have a look at the acid-base balance. Do you guys have any questions so far? So this is the last thing we are going to discuss today. Any questions, guys? Hello. All right. Okay. So we'll discuss about the acid-base balance. It's really important to know this acid-base balance, guys. It's not just for the aspirin thing overdose. Commonly, like there are a lot of drugs and conditions which can cause acid-base imbalance. So you have to know this normal physiology of acid-base balance. So lungs is the something. So the main two organs which control the acid-base balance is lungs and kidney. So how do the lungs do his job? Is it controls. So again, lungs is acidic. It controls the carbon monoxide. Sorry, not carbon monoxide. My bad. It's carbon dioxide. And the kidney is bicarbonate, which is a basic medium. So in case of hyperventilation, what is hyperventilation? Increased. What is hyperventilation, guys? High rate of breathing, right? So the breath rate is very high. In case of hyperventilation, it decreases the CO2. So you might be wondering, if the patient breathes very fast, isn't it too? No, it's not. The CO2 level will decrease. Just imagine if you breathe like the amount of air goes inside the lungs will be decreased if you breathe so fast. You have to breathe normal, or if you have to take a very slowly, take deep breath, and the amount of air goes inside is high, right? So in case of when it comes to hyperventilation, the CO2 goes down. So we said CO2 is acidic. So CO2 converts to carbonic acid and it controls acidic medium. So it is acidic. Now, if the CO2 in hyperventilation, if CO2 goes down, it can cause what? Respiratory alkalosis. Okay, are we clear? Now, what if hypoventilation? Hypoventilation means decreased breath. So in case of hypoventilation, the CO2 goes high and it causes respiratory acidosis. So it's very easy. So again, lungs controls the acidic. So CO2 CO2 converts to carbonic acid and it controls the acidic balance of the body. So hyperventilation, the CO2 goes down, it causes respiratory alkalosis. In hypoventilation, CO2 goes up and it causes respiratory acidosis. In kidney, bicarbonate, which is base, which we already know, and if the kidney eliminate more bicarbonate, it causes, because we are decreasing the basic medium, right? So it causes metabolic acidosis. See, so when it comes to kidney, it is metabolic. So more elimination leads to metabolic acidosis and less elimination leads to metabolic alkalosis. Okay. Now we know the difference between metabolic acidosis and metabolic alkalosis, also respiratory acidosis and respiratory alkalosis. So how do we know when the patient, how do we assess the patient if the patient have the alkalosis or acidosis? So that's we are going to discuss in next slide. So we know the normal pH is 7.4, right? So first we differentiate if the patient is acidosis or alkalosis. So if the patient pH is below 7.4, that means patient is acidosis. If the patient pH is above 7.4, that means the patient is alkalosis. So we know that if it is alkalosis and acidosis. Now the concern is if it is respiratory acidosis or metabolic acidosis, or if it is respiratory alkalosis or metabolic alkalosis. So how do we know that? So we check for the partial pressure of carbon dioxide. And if the partial pressure of carbon dioxide is very high, okay, so again, if the partial pressure of carbon dioxide is very high, so we said that if the carbon dioxide is acidic, if it is decreased, it causes alkalosis. So if it is increased, what is it? It's acidosis, right? So just imagine CO2 as acidic. So carbon dioxide acidic. So if it increase, if partial pressure of carbon dioxide is increased, that means it's respiratory acidosis. If the bicarbonate level is low, which is a base, so that means if we check the lab, we do the lab investigation and comes to partial pressure of carbon dioxide is okay, but it turns out the bicarbonate level is low, that means the patient is having metabolic acidosis. Okay. Similarly, like in alkalosis, if the partial pressure of carbon dioxide is like low, that means respiratory alkalosis, and if the bicarbonate level is high, that means metabolic alkalosis. So we are clear now. Now we need to know how the body. So we said that it's acid-base balance. How the body balance the situations, these equations. So let's take one by one. So first, the partial pressure of CO2 is high, which confirm that it is a respiratory acidosis. So now renal compensation starts to happen. So in the body having acidosis, high acidic, so acid-base imbalance, right? Now the body has to balance the acid and the base in the body. So now the patient having respiratory acidosis. So what does the renal does is renal reduces the elimination of bicarbonate, okay? And in terms, what happens? It increases so it's reducing the elimination, right? So when it reduces the elimination, what happens? So bicarbonate level is not, so base is not going out. So what happens if the base is not going out, guys? So it leads to, what happens? Come on. If the base is not going out, it leads to alkalosis situation, right? So acidosis is compensated with a alkalosis. See how the body is balancing it? So reducing the elimination, that means the bicarbonate level is going high and the patient have the acidosis. Now the bicarbonate is getting high in the body and it compensates the acidosis. When it comes to metabolic acidosis, okay, metabolic is, we know that the bicarbonate level is too low, okay, which lead to acidosis, right? Now the patient, what happens is respiratory. So whenever there is a metabolic condition, the respiratory system try to compensate that. Whenever there is a respiratory situation, the renal try to compensate that. Okay, so in metabolic acidosis, respiratory system compensated by hyperventilation. So the patient start to hyperventilate, and what happens is, like in hyperventilation, the CO2 is very high, less, right? So it leads to alkalosis. So again, acidosis is compensated with alkalosis condition. So that's how the body is maintaining the acid-base balance. Similarly, like vice versa, in alkalosis, if the PaCO2 is if there is a respiratory alkalosis, renal try to increase the elimination, and it leads to acidosis situation. And if it is metabolic alkalosis, respiratory try to compensate by hypoventilation, thereby increasing the partial pressure of CO2, and which leads to acidosis situation. Okay, so I hope it's clear for you guys. It's not too much complicated. I tried to put in as easy as possible for you guys. It's really easy. Like first we have to see the pH. If the pH is less than 7.4, it's acidosis. If it is more than 7.4, it's alkalosis. Then we check for the partial pressure of carbon dioxide and bicarbonate level to differentiate if it is metabolic or respiratory. In respiratory situation, renal try to compensate. In metabolic situation, respiratory try to compensate the condition. Now, do not confuse that the metabolic acidosis or respiratory it's not like converting. The metabolic acidosis is not converting into something like respiratory alkalosis or something. There is no conversion. It's just the way of body to try to compensate the thing. Okay, so do not confuse with conversion. A lot of people try to say that students confuse with, if there is a metabolic acidosis, patients, it will convert to respiratory alkalosis. It's not like that. It's just the way of body to compensate the things. Okay, and we already know how to do the metabolic. If there is a metabolic acidosis and metabolic acidosis, we give the bicarbonate to the patients, and we can manage the condition too. All right, so that's all for today's section. Actually, that's all. So do you guys have any questions so far? So we covered the antiplatelets, we covered the unfractionated heparin, we discussed about the dosage adjustment based upon the APTT for the heparin, and we also discussed the perioperative management of antiplatelets. We discussed the acid-base balance. So I guess that's would be enough for today. Tomorrow we'll be discussing about the anticoagulants, warfarin. So just prepare, be ready for it, because we are going to discuss the warfarin dosing adjustment in perioperative, and also how to adjust the dose with INR. So it's going to be easy. And we also will be discussing the acute coronary syndromes tomorrow. Okay, so just prepare for that. That's all. So do you guys have any questions? Any questions, guys? No questions? All right. I hope there is no questions. All right. So I hope everything is clear for you. So it's not much difficult things here. So it's pretty much everything was straightforward and easy to remember. So yeah. So enjoy the rest of the day, guys, and I'll see you guys tomorrow. All right. Okay.